All right. Hey, guys. Welcome. Jamie, Christine, Burkhard, the rest of the team. Amar Krishnaswamy here. I've got my co-moderator, Charlie Davidson, and a fantastic panel. We're all looking forward to seeing your case. I'll just go down the line, have everybody introduce themselves, starting with you, Brian.
Excuse me. Thanks, Amar. Brian Wisnett from Intermountain, and great to see the team there at Washington. Thank you.
Rob Smith from Baylor Plano. This is an exciting case. Look forward to it.
Hey, Charlie Davidson from Northwestern. Looking forward to the case today.
Fabien Prat from Bern, Switzerland. Hi, guys.
Hi. Brian O'Neill from Henry Ford. Jamie, it's good to see you and the team.
Nicole Karam from Georges Pompidou, Paris.
Nadir Ahmed from Minneapolis.
All right. Well, can you hear me okay?
Absolutely.
Yeah, welcome.
Sorry you took off your costume to put on surgical scrubs, but.
Well, welcome to sunny Seattle and University of Washington. I'm Jamie McCabe. I'm joined, as you heard, by an awesome team today. Burkhard Mackensen, Grand Poobah of Imaging, Christine Chung, one of my interventional colleagues, Oscar Midas, our structural fellow, Alyssa, our tech. We've got Michelle as our CRNA, Amy, the nurse. Richard Shu is our anesthesiologist. So really excited to be here. Why don't we just jump right in? And Oscar, would you present the case, please?
Absolutely. So this is a 77-year-old female who has atrial functional disease, severe tricuspid regurgitation with NYHA class 2 symptoms of dyspnea on exertion. She has had multiple heart failure admissions. She has severe atrial functional MR as well that was treated with successful Triclip. However, she had persistent tricuspid regurgitation. This patient also has persistent atrial fibrillation with atrial fibrillation, in who we performed cardioversion, but she had recurrence of AFib. Importantly, she doesn't have any pacemaker leads through the tricuspid valve. She has CKD stage 3A with a creatinine of 1.1 and GFR of 52. The medication list as shown. Next slide, please. Dr. Mackensen will show you shortly how the tricuspid valve looks, but in these pictures that are from a transthoracic echocardiogram show severe TR with a dense envelope of the TR jet. And there's also evidence of hepatic vein flow, systolic reversal. Next slide, please. So for this symptomatic severe patient with severe functional tricuspid regurgitation with multiple hospitalizations for heart failure and symptoms that are ongoing despite successful MitraClip, our procedural strategy are for using the Triclip G4 system for a transcatheter edge-to-edge repair, and it will be done with a TEE and ICE guidance.
Thank you.
Yeah.
All right. Any questions about that, or should we just jump right in and start showing you some echo pictures?
Why don't you guys jump right in so we've got time to really review the case as you do it.
Great. So Burkhard will take us through here in just a sec.
Yes, well, it's great to have everyone there. Start with a transgastric view of note. I got this a little bit later in the pre-procedural imaging, going deep into the stomach and really looking back, and then got this relatively clear transgastric view, which again shows the septal leaflet, anterior leaflet. There's perhaps a bit of a two scallops situation. And then posteriorly, there seemed to be a distinct jet as well that we're going to see in a few other images. Again, just scrolling through, a pretty central TR jet. Again, you see the distinct posterior element, which we'll get to in a bit. Again, without color, you see the defect, the malcoaptation in the very center of the valve. And if I go to some of the 3D, we've actually looked a little bit in kind of how we're coming down. We are not down with the device yet, but use some multiplanar imaging in order to align ourselves. If I use the 3D color image, it's really helping to then use the left lower short axis, where septum is here, anterior is over here, to kind of use the red plane to kind of come in and out of the jet as you see it coming in. And I can jump into the main bulk of the jet. Right now here in this particular image appears to be a little bit more posterior, but again, that all depends on my blue plane and how I orientate the blue plane, how far it comes forward. Again, just inching up to the main jet. We see that here. If I go to some other images, again, severity of TR, I think is no question in this particular case. I can show you a sample of that here. Here you now see the central component and perhaps that distinct, more posterior part of it. Again, a pretty significant jet. If I were to show you the situation without color, have it here, hold on. There you see the malcoaptation in the right upper view now. Again, we consistently, as Nadira would do it, have our posterior and then septal and then septal here, the anterior component or lateral leaflet, as we often call it over here, to be consistent. So it's along this line, the green line, that we can move the red plane to construct our right upper grasping view from this position. To give you a couple more impressions in terms of severity, we talked about systolic flow reversal in the liver. You see that here both in pulse wave as well as color Doppler. And again, some mid-esophageal views showing the same pathology with a pretty far-reaching jet that reaches all the way to the intra-aortic septum, as you see it here.
So this is beautiful imaging there. You know, Christine, based on this assessment, what is your and Jamie's plan as far as where you want to put the clips and how you want to plan that?
Well, I think, you know, we were chatting about it earlier, and Christine, feel free to jump in. You know, we typically start anterior septal when there's opportunity there. I think you can think of it a little bit, you know, if you're familiar with Triclip, the idea that you fold down posteriorly, you kind of want to start, medial and work lateral. In this case, in tricuspids, my impression, my experience is that we start anterior septal and kind of build posteriorly, and that I think is going to be our process today. So we've got XT clips. I prefer XTs over XTWs, though I'm not sure everyone would feel the same way. So that's something I guess we could discuss. But we've got an XT in there. You know, just to sort of start from the beginning a little bit, there's not a lot of fluoro here, but I always put the delivery system with minus on up in the SVC so that the clip can come out and just in case the delivery system is headed right at the septum, you know, you don't bring your clip out and like jam into the septum. So I bring it up into the SVC, then I draw everything. I don't know if this plays. Then I draw everything backwards and start to fold down. We used MPR to kind of get some alignment. We have just a touch of lateral on, which is a Triclip specific feature. It sort of swings you both lateral or antiseptal as well as down and a slightly posterior. So we put just a hair of that on while we were trying to get our alignment. We're in an REO 20 fluoroscopic view, which is usually where I start. And in that view, you kind of want to see the clip arms kind of overlapping each other, which gives you a broad sense that you're in the right orientation. And then just keep in mind on the fluoro aspect, if you're looking at the fluoro, for those who don't do a lot of these, the anterior septal commissure is up at like 2 o'clock on the screen. Posterior septal is down at say 7 or 8 o'clock, just as a general frame of reference. So we're going to use that to sort of figure out where we're going. If you want to get more anterior or anterior septal, you can push the whole system in, or you can take flex off. If you like your trajectory, but you want to go more central or more posterior, you just pull the whole system back. If you don't like your trajectory, you can add more flex. So that's sort of generally how we're going to move around, though we'll try and talk it through as we go. You can see that the system has warmed up a little bit. We've kind of come a bit out of our trajectory, but I think we're okay. We already checked our grip arms, so we're good there. So I think, Burkhard, if you're comfortable, we're going to come down now.
Yeah, let me quickly align perfectly where you are. We talked about the position beforehand. So now you see the clip delivery system in both upper views, and he just dove into the short axis as well. Left lower image shows that point of entry underneath the leaflets.
Yeah. We'll just open down here.
I notice you're going in closed and then opening up underneath the valve, Jamie. Is that your typical, or is there something about this case that you decided to do that?
It is kind of my typical. I feel like with the long arm clips, if you come down, it's more often that you can kind of swing around. Maybe the leaflets sort of push you around a bit. So just find it easier to go down a little bit close.
Yeah, Jamie, that was an interesting move, because I find that when I'm open and I go across the valve, that I do have the tendency to spin a lot, and based on the fluoro, it looks like your clip arm stayed pretty much in the same trajectory there. So,
you want me to do a dedicated short axis for?
I would love that. Yeah. So
so
our typical, once we come under, is we check our orientation and our position in a transgastric short, as long as you have a transgastric short to see. And in this view, as Burkhard will point out, the anterior septal commissure is down towards like 4 o'clock, and the posterior septal is up towards midnight, 12. So we're too central here. I think we want to be more anterior septal. So we can do one of a couple things. We can either unflex a little bit, which I think I want to do just based on the fluoro, come up, and that'll bring us down. That'll fluoroscopically we'll go up. By TE, we'll go down, kind of like that a little bit better, and then we can also potentially push in. Though I'm kind of happy. I'm not up. I'm going to try and use English. I'm reasonably happy there. What do you think about that position? I give it a little counterclock.
Yeah, I like that.
Importantly, for how you're planning the case, you've got some nice room posterior to this clip to get more anterior and septal on a second clip, if that's your ultimate strategy. It seems like a nice spot. I'm sure Burkhard will confirm the color and the grasping there with 3D MPR shortly.
Yeah.
While you guys are confirming, let me ask our panel. So Jamie mentioned he likes the XT. Brian, let's start with you and just go down the line. What do you tend to default to on your clips for the tricuspid?
XTW.
Any specific rationale?
I haven't had a lot of issue with chordal entanglement, and I feel like just grabbing more tissue is what I do, but I'm not opposed to XT, but I tend to use XTW.
Gotcha.
I do it because I think that the lock tolerances are less good on XCW. So I have my first clip. I don't know if you saw that. I was going to show you that, you can see the neo carina here. We've already got it. But the leaflets stopped moving. As I came up, I drew up in the transgastric short, and you could see the leaflets stop passing the leaflet arms. At that point, you've got it. So I just dropped both grip arms. I locked it and closed it, and we'll confirm it. But anyway, we have it.
So can I ask you guys there? You didn't move out of the gastric view when you actually put your grippers down, unless we weren't seeing your live TEE. Did we miss something?
No, it was live and transgastric short. If we do have such a good visibility of both leaflets and we come up, then we often confident there that we actually can do the grasping. Obviously, we confirm it from different points of view. And if the transgastric is not as clear, then we would go to midesophageal for sure.
There you go. In case you didn't.
Do you get baseline ICE imaging on these, or do you just wait till you need it later on?
What do you? I know you have a ton of experience with this, Charlie. What do you do?
Well, I think the septal leaflet wasn't super visualized on the TE, so I think I probably would be liberally using the ICE. I don't necessarily do it necessarily up front, but I would like to look at the landscape, I guess, to see if it's going to help me or not.
Sure. Yeah, I mean, I guess I would say that we don't open it in every case. Obviously, there's a financial component to that, but certainly when you don't have wonderful grasping views, it is a lifesaver. We put it in here, and we're gonna, we'll certainly go to it and see if it can corroborate our grasp and so forth. But I don't tend to use it up front very much, mostly just because I get lost. I kind of look around, and I'm not exactly sure where I am at any particular moment. I'm probably just not that good at ICE.
No, well, look, lately I just park it in the RA, get one shot of the tricuspid valve, and let the echocardiographer do the rest of the work. Which that's up my alley then.
Yeah, back to the grasping here. I don't know how well you see the left lower image. I can zoom in a little bit, but essentially we can now, with the red plane, almost do like a biplane or X-plane interrogation, kind of come in and out of the clip here, and you see the short axis. Both leaflets seem to be solidly in.
Yeah.
Jamie, did you want to use ice to just take a peek?
We got it. Let's do it.
Okay. All right.
So let me, while you're getting that set up, Fabian, maybe I can ask you, in the European experience, where does ice factor in for you?
So we use it mainly as a complementary technique with TOE. So we always have TOE with us, but in the situation where we don't see enough the leaflet, or we anticipated some difficulties to see the leaflet, then we will use the ice. So it's not a systematic use. I know that some centers are using it, to kind of accelerate the procedure, or see the leaflet having a higher level of confidence on the leaflet grasping. But we limit it to actually two cases where we anticipated an insufficient imaging quality.
That looks nice.
Nadira, what's your practice?
So basically as a complementary adjunct, mainly because of the cost, but we use it when we can't see it. So, I think TE first, and if I can get very good views from mid-esophageal, distal esophageal, or transgastric, and we can do a case without the ice. So when I have difficulty, then there's no hesitancy in opening the ice catheter.
I think it's good to keep in mind that the most recent data I saw was 62% of commercial Triclip cases use 40 ice. So it's a pretty significant number.
Yeah.
All right, Jamie and Christine and Burkhard, why don't you get us back to Seattle and let us know what you're looking at?
Yeah, so right now we're looking at the minus 35 angle and a right-sided view. That is the grasping view. And the way we got there, we took a shortcut with 0 degree first, but then set up for a biplane imaging. Alternatively, we can come from a 3D image and kind of dial in, but this seemed to align pretty well, so we can actually, if Jamie gets the clip back in there, I can use my tilt plane and actually interrogate the insertion of the leaflets right there. You see it pretty well, I think, on both sides, lateral and septal would be here.
Yeah. Good tension on the septal leaflet there.
All right.
And I'll point out for anyone unfamiliar with the ice, this is the Phillips Verisite, and you could see at the top that Burkhard had changed his angle from 0 degrees to 55, which aided in really getting a perpendicular view to the grasping arms.
Okay, we're going to let this one go and move along, because this is a bit of a step in the direction that we want to go.
So what's your plan, to go parallel or clover leaf? What are you thinking?
I was thinking we're going to go parallel, at least for this next anterior septal. We're just building towards the center a little bit. And so the next one will be a little, central to the first, but parallel. And then we'll see what we have at that juncture. I think we sort of favor that kind of trying to bicuspidize the valve. That may not be a great solution here, given that sort of the discrete posterior jet, but it's generally a preferred approach. If I can see if this guy will let go of our clip. There it is. Okay.
While you're releasing and setting up for the next, Christine and Jamie, just thoughts on, especially given recent one-year Triluminate data from this conference, TCT, thoughts on sort of the durability that we see with tricuspid valve clipping, especially in a situation like this where you've got that dilated annulus and so forth?
Yeah, so somewhat recently, the Europeans released their 3-year follow-up from the BRIGHT registry, which was the post-approval registry in Europe. It was about 100 patients, and they actually had over 80% of patients having moderate or less residual TR, which is kind of similar to what we've seen at the 1-year mark across the randomized as well as the single-arm prospective registry of Triluminate. So all of those have shown 80 to 90% of patients have moderate or less TR at 1 to 3 years.
So a couple of interesting findings from my end right now as I'm looking at the remaining TR. I think it's central more than posterior. And if you look at the 3D that I just actually acquired, if I show you this image here and I actually rotate, take a look at the severity here as opposed to when we first started. I'm just going to show you for reference. This is the baseline assessment. I think we can, despite the fact that we aim to be strategic with the first one, we can see that there is already decrease in severity that's pretty obvious. So it's always good to have a complete baseline.
Yeah.
How about using the transgastric short at this point to look at your residual TR? Another way to kind of plan out that second device. I don't know, Rob, what's your plan on these types of cases?
Yeah, I mean, I think the biggest thing here is being able to adjust to whatever you found that you just did,
right?
Because it's not always exactly as you had planned. This was this is a really nice reduction, and so it'd be nice to look at kind of a 2-device strategy here, and probably just going right over towards that a little bit more posterior aspect. I bet you're going to get a great result.
Oh, there it is.
That's nice.
That's a nice reduction.
Yeah.
Yeah. All right, so we just came back in. I kept all the same settings on my sheath and just sort of brought the clip in, flexed it down. I'm orienting now under fluoro so that I have aligned my arms. While we're up in the atrium, we will open up and check our grip arms and get our orientation. I need to go a little septal. So that's the button is septal. Non-button's lateral. I should have mentioned earlier, just to clarify, that with the catheter, if you rotate away from you or clockwise, you're going septal. If you're coming towards you or counterclockwise, you're going antiseptal or lateral or anterior, though that really works best when you're anterior septal commissure. Once you start to get to the posterior septal commissure, when you rotate towards you, which should just take you lateral, it kind of takes you lateral and anterior a little bit. You're just not necessarily orthogonal to the plane of the posterior and septal leaflets, which can make things a little more challenging. So which is why, I don't know what you guys think, but I find the posterior, it's got a greater cord, it seems to have greater cord density and is just kind of a more miserable place to hang out. All right, I think I probably have too much flex on, but I'm going to come take a little bit of that off. I just have a sense that I'm probably a little overflexed, and I'm going to pull backwards a little bit. That's going to bring me central. And then, Burkhard, I think we're pretty good to come down here. Would you agree?
Yeah.
Great. It's nice when he agrees, actually. Okay, so we'll open up down here.
Looks like fluoroscopically a little bit divey posteriorly.
Yeah, I agree with you. So we're gonna, but I kind of, I'm not gonna lie, I kind of prefer that because it's, you know, you don't jeopardize the first clip. You can open up and then that mitral clip makes the fluoro weird, but you can open up a little bit and then just take some of that flex off and come closer to the other clip. I don't know that we need to be super close. I'm gonna open up a little bit more. I'm just coming up here a little. Should be about it. We're going to go a little septal, which is clock away. Do you like that position, or am I too close to the other clip? I think it's okay.
I think it's okay.
Yeah, maybe let's look at the color maybe from there, because you might be able to get a little more posterior, be away from that other clip, because it does bleed more posteriorly. Right from the beginning it did.
Yeah, sure.
I don't know.
Yeah, that's fair.
So, Jamie, before you close, also show us how you're assessing leaflet insertion.
Sure.
I thought you did such a nice job with the transgastric grasp here, and you showed very nicely, but we didn't stop for a minute to really show us how the leaflets were laying on the clip arms.
Yeah. So right now on the lateral side, you can see that I'm a little in the cleft, so I've come a little more posterior, and I think that I'm a little more towards the cleft, so I actually probably want to go in just a hair more. I think. What do you think, Burkhard?
Yeah, a little bit more.
More anterior. Yeah. So I just pushed the whole system in a little bit. I didn't flex or unflex. I just kind of physically pushed the system in, and I'm going to pull back here a little bit more. Yeah, sorry, go ahead.
It's always important. I just pushed in to see him a little better. The clip, it's underneath the leaflets. If I let go like this, I only see the delivery system and not the clip arms. So now it's kind of a give and take a little bit.
Mm-hmm. So
see, right now it's very clear you've got great insertion of the lateral leaflet.
Yes, and I think I have septal too.
In terms of your orientation, Jamie, you feel like you're a little bit too clockwise, or you like it?
I Man, I'll take a scooch. I feel like that was a leading question. I'll take a scooch off for you.
I like it, Jamie.
Okay, I was kind of happy here, but whatever. Let's try it. So I have both right now. I know I have both. So I'm going to drop both.
Okay, so show us how you know you have both real fast.
Because they just don't go past the leaflet arms, and they kind of freeze there a little. And I guess maybe that's just something you have to see a few times, but when you don't have them, you'll know it because it is they move like natural, and now they're not moving like natural. So
we see them coming into the middle of the clip, not to the tips of the clip, right?
Yeah. So if I freeze that, actually, I can go back to show this whole and replay it, so you can watch it again. Clip is open, and I would point out that up there, you may see some septal leaflet that is inside of the clip arm, and we saw that at the beginning even a little bit more. And now as he closes, that's coming more in.
Yeah.
But it's just a replay.
Yeah, and then we talk about a neocarina, meaning that there's a tight V that comes to the center of the closed clip. If you get kind of more of a U shape where the leaflet comes into the clip but is sort of wide, or there's a broad base, I think that means you have more of a leaflet, sort of a tip grasp. So you really want to see the leaflets come really into the center of the clip, and so that's something we'll be looking for here. And then, of course, we'll corroborate.
And so this is your default strategy, is to grasp and close entirely in the transgastric short axis like this, or do you often go to mid-esophagus?
When we have it, I use it because we've just, kind of recognize what it is, and it makes life easy. If you don't have it, obviously we go to mid-esophagus. And I don't see a great neocarina here, I'm going to admit. I think I see that that lateral leaflet is coming sideways into the clip a little bit. Do you see, Burkhard, you want to point that out?
It's like a side pipe.
Yeah. Yeah. So I'm not in love with this, honestly, and I think we'll unlock and open here.
Well, they optimize. Nicole, let me ask you, what is your sort of typical strategy? Is it in the gastric imaging? Is it mid-esophageal imaging?
No, honestly, I just align in the transgastric, but for the grasping, I prefer to go to transesophageal whenever I can, unless it's not optimal.
Yeah, I mean, we can go to, you want to go to esophageal?
Quite often we do grasp in the mid-esophageal. I think these lend themselves to do it here. That's why we just continued on.
Yeah, but I'm happy to go to mid-esophageal. We have good views of there, I think. So if you want to look there, that's fine.
What do you think of orientation here before we go there?
I'm going to go a little bit of clock.
We sometimes have challenges seeing the septal leaflet in the mid-esophageal, and so we'll come to the transgastric to be able to see kind of what Jamie's explaining here. You can really see the leaflets coming in, and so if you're either not sure in one view or the other, you can come to the other one to help corroborate it.
Jamie, are you thinking 3 devices or 2 devices in this case?
I was hoping that it was 2, but I'm not sure if it's going to be 2 or not. We'll see.
I kind of wonder if you got more onto the posterior leaflet and a septal grasp with that. You'd have a little regurg in between and a little bit posterior left, and you might be done. But, what?
Yeah, well, let's see
what
we
get choice here.
Yeah.
I don't know, Brian, what are you thinking down there?
I mean, the short axis, when the clip was closed, looked like there wasn't very much TR. I don't think we can ever fully assess TR until we go into the mid-esophagus. But, there was, when we started out, there looked like there was a large, very posterior jet. So my initial thought was 2 anterior and 1 posterior. And I think we generally like to do that. And especially since Jamie can do it 3 clips in about 10 minutes.
Yeah, really.
Most of us, it takes 2 hours, but for as fast as Jamie, you might as well do all 3.
Well, I think so. There's close to 60. I think we got them both. It's kind of been in and out. It's a really lovely view, but we're getting a little shadowing maybe. So that. I
think we're seeing septal really well there. It looks super tight.
Yeah. So I can just do a little give back, and let's just close. What
You're still at 60?
I'm it's 40, 30, 20, 10.
60.
There we go.
0.
Now I see the lateral is now tensed as well. I think it's pretty clearly seen there. I can gain up a little bit, maybe. Now, for the imager in the audience, I think it's important here to play with your multiplane angle on the left upper. It's 55 now, so if you work more towards the posterior aspect of this commissural view, as I call it, then you need to lower your angle to get a good right-sided grasping view, which we have here. If you're more central, more septal, then if I were to image here, where the first clip is, I would have to increase my multiplane. There we go. Looks like we're right at the septum there with the device.
Grabbed a little annulus.
Oh, it looks awesome. We always do confirm in transgastric before we release, though.
Yeah.
That's kind of everyone's standard practice.
It's really
still have a jet more centrally.
Yeah. Yeah, a little eccentric there, huh?
A little bit towards the corner.
You know, Burkhard, can you show us a 3D data set there and try to help us understand a bit of the location and the residual leaking, and then what kind of grasping leaflets you have left?
Yeah, we'll do.
So while Burkhard's getting that, I'd like to sort of ask our OUS colleagues, you know, you have commercial access to the Triclip device and to the Pascal device. Are there particular anatomic scenarios that veer you to one device or the other, or what are your thoughts?
I mean, you know, that's difficult. But basically, what is one of the advantage of the Triclip, like used right now, is the quite powerful annuloplasty effect, and that's something you see really when using the Triclip. This is present also with Pascal to some extent, but maybe a little bit less. So when you do a Triclip, you can see, as you saw in the first grasp, you can see tricuspid regurgitation just disappearing outside of your grasping area, which is a sign of probably, you know, reducing the size of the annulus. But you know, we don't know exactly. You know, I think both devices can be used in most anatomy in different way. You should use probably the one you are the most experienced with, because you know on the tricuspid valve you need to have your skills, your full skills, and use the device you are feeling the most confident with. So I cannot give you, you know, anatomical criteria for choosing it. Obviously, Pascal is a little bit more physiological in terms of the way it grabs the leaflet, and that can play a role in extreme situation with very small leaflet, where you attempt also several grasps.
Nicole, what's your thoughts on that?
Well, I'm in France, so basically Pascal is not yet reimbursed on Tricuspid, but I've used it when I was in Germany. I agree totally with Fabien that we do want to have this annuloplasty effect, and obviously we will have it more with Triclip, even if we will see a bit of it with Pascal. But otherwise, it depends on what we are more used to also.
Do you think any of, like, one is better on chordal navigation, or do you think they're both fairly equivalent?
I mean, clearly with the Pascal, you can elongate the device. So if you get entangled, that's probably something that is very useful to get out of this critical situation. So that's another advantage, I would say. But you know, that's a situation you should try to avoid as far as possible.
But I would love, for when we are talking about Triclip, I would rather go for larger ones, for wide devices, rather than, I don't know, Fabien, what's your experience, but I'm rather on XTW than on XT.
I mean, in Europe, we use mainly XTW for the tricuspid valve, but you know.
I don't think
in the U.S. commercial experience, more than 90% is XTW, which is myself, and it sounds like Jamie also. We always default to XT, not XTW, just because I feel like I can get the clips closer together with the XT rather than XTW. But I guess Jamie and I are not the typical U.S. operators, as Brian is.
Maybe it also depends if you are going for a bicuspidation or for a clover. If you don't have the intention anyway to go close to the first clip, then why not have an XTW? If you are intending to do both on anteroseptal, then maybe it makes sense to have an XT.
Jamie, let's get back to you here.
Yeah.
Tell us what you're doing now.
Well, we just, we're looking at it, and Burkhard can take us through it. It looks like it's just, there's still that posterior discrete jet that is, it's not that we're missing just a little central with this second clip. I think it is just a bit remote in that posterior septal commissure that there's residual leak. Would you agree with that, Burkhard?
Yeah, but it's not as far posterior as we initially thought. I think if you look at this en face view, if I rotate a little bit, actually see the bulk of the jet is not too far from this current clip. I think we had such good ICE image. If we take a quick peek, we can assure ourselves one more time with insertion, and then maybe also look a little bit more centrally and see how that shapes up. Again, remind the audience that ICE always blows up the TR quite a bit, so we'll see it probably a little bit bigger.
Yeah, change the Nyquist limit until it looks great, would you?
120. So, Jamie and Christine, how do you think about this? If you say it's relatively close to your posterior clip, how do you think about putting a third clip versus just moving this one a little bit backwards? What are your thoughts?
I think I guess I would say that if it depends on a matrix of things. One is, how difficult was it to grasp this time, and did you really work for it in a way that you don't want to give it up? Second is, do you have a grasping target that is sufficiently large to accommodate an additional clip or not? Obviously, if you don't, then you're going to want to optimize this one. That would favor optimizing this one. If it was really hard to grasp this one, then you're going to want to favor leaving this one in. I think we're not terribly shy about using a third clip in our tricuspids. I don't know what our data would tell you, but I tell my patients that it's a 2 to 4 clip. Triclips are 2 to 4 clips in general, in my estimation. And I guess with bicuspidization, I think that's part of that is that to overcome substantial coaptation gaps, you really need to start in the commissure and kind of zipper the leaflet together. And we end up doing a fair number of those. Part of it is just because the tricuspids are often really dilated. It almost looks like that eccentric jet is our problem. And is there just, where's the septal leaflet there?
Yeah, let me play with the angle a little bit to see. Take the color off. Don't see it really well.
Yeah.
Can I suggest something? There's a possibility, Jamie and Burkhard Nadera here, that there might be some cords, and I think just check the transgastric for the orientation. It looks like you see the tilted, and I think there wasn't enough grasp of that septal. So when you color it here just now, Burkhard, you could see the jet through that septal. That's, I think we probably caught on cords. I think we should, re-optimize the septal leaflet grasp. But I think to check with the transgastric as well, the orientation, that's my gut feeling.
Yeah, that left image right side does not look as good as the first device.
So over here, though, we do see pretty good insertion, right?
Yeah.
I mean, what are your thoughts on making a 3D data set, putting your grasping plane on the clip, and then just opening it up while you've got the grippers down and see what you've got underneath the septal side?
Well, I mean, I can open it here. We saw in the transesophageal grasp that we were like at the limbus, so I'm not terribly worried about how much tissue we have. Whether we brought a cord with us, I don't know. It's possible. And one aspect of a midesophageal grasp is that you can twist the clip inadvertently. So it's possible we're out of orientation. The transgastric is such like the security blanket of this whole thing. Why don't we go to that and see what that looks like, and then we can decide what to do. We can open or not, kind of.
So just one more thing here. I just changed the angle, multiplane angle on the right side. Again, illustrating that grasp a little differently. Again, I would suppose that looks pretty good here.
It looks pretty tight, and frankly, your color will look pretty good too. There was not a lot of volume to that color. I mean,
if I go right into the
pretty darn
color,
good result, especially with ice.
yeah, usually with ice it looks even bigger in your face.
I mean, this is like zero.
Yeah. Well, let's go to transgastric. I think that's.
Yeah, no,
it feels good. It feels warm that way.
So we're back to TE.
I will say that it's really, I mean, not to blow sunshine, but it is a really nice aspect of the Verisight that you can toggle back and forth so easily. I do enjoy that part of it.
So if you guys don't mind, we're just going to keep you on, of course, and we're going to keep watching what you do. But I just wanted to turn it over to Michael Young on the whiteboard, because we've had a lot of learning in the last 25 minutes. We'd like him to review for us what we should take away so far.
Great. Can you hear me okay?
I think it's a good Neo Carina.
Yeah.
Jamie and Christine.
And I think we have an opportunity to go
fantastic work here
again. Yeah.
I'm just going to highlight just a few of the points to just digest here. We'll start with number one, since I'm right next to Nadir, role of the interventional imager. Okay. So what we've learned from these tricuspid cases through all the trials and as commercial rollout has happened for Triclip, is really important to build up the interventional imaging team and highlight the role of the imager, because without the imager we wouldn't be able to.
So I think we just do a third very close to the first.
Also,
similar orientation too.
Mention that there is going to be a lot of I think opinions and data, hopefully, in terms of what the experience should be like in training standards for these cases, because the sophistication of the imaging, the type of views that you need, are a little bit different from the standard imaging views that perhaps those of us who trained in a different era were used to. So there's going to be a lot more of that to come. Being familiar with transgastric, multiplanar reconstruction, some of the dedicated home and other imaging views are critically important. In terms of manipulation of the device, there are some parallels between, of course, mitral tier and tricuspid tier. There are the flex and extend knobs, the ML knobs that parallel some of the movements for the various mitral tier devices. The anterior-posterior movement, moving the device forward or the sled forward and back, are not too dissimilar from the concepts for mitral tier when you're going lateral or medial in the mitral valve annulus. Fourth is the role of complementary ICE imaging. I think those of us who have access to 3D or quote-unquote 4D ICE can really say that it can be a game changer in some of these cases where the imaging is particularly difficult, either in the grasping views or the transgastric views. So I think ICE imaging, we'll see how much of a standard that needs to be for every single case, but it sounds like there is a movement to utilize it more upfront during our procedures. I just wanted to highlight the approaches when people talk about bicuspidization versus cloverleaf. These kind of emulate the K procedure for bicuspidization. So you're essentially, if this is a interventionalist primitive diagram of what an echo imager sees, but you can see septal, anterior, posterior leaflets, and so you're just trying to bicuspidize either with 1, 2, or like Jamie said, 3 devices to reduce your tricuspid regurgitation. And then for the clover leaf, it may be this type of situation where you put one device septal to anterior and one device septal to posterior. So that's another sort of conceptual approach that for tricuspid tier. Being aware of the outcomes, T-tier is safe and effective. We have real-world data, of course. Triluminate data shows us very safe, quality of life improvement out to 1 year. And then the class 2 clinical trial data will be forthcoming. Charlie's the head PI of that trial, which we're excited to see come to a conclusion. And then last couple items, deployment, confirming insertion. Folks might not be used to this if you're more used to mitral tier cases. But this transgastric view is critically important, so you can see the insertion of the leaflets into the arms of the device, whether it's, in this case, Triclip or Pascal, and this is the closed position. And oftentimes you can see those leaflets kind of come in. Last, I'll just say points for perhaps discussion and think about device selection, annular reduction. There we go. Annular reduction. How many devices to use? I heard a quote in the last session, perfection versus pragmatism, which is always interesting. And then the other thing I noted was that, maybe radiation protection, not just for the implanters, but for everybody in the room, including the nursing staff and the interventional imagers at the head of the table. So bravo to Jamie. Dee Dee Wang asked to put emojis up, so I had the honor. That took a little while to figure out, but nice job, Jamie.
That's great.
Nice
Michael.
job.
Thank you so much. Fantastic. That was wonderful. Jamie, Christine, Burkhard, let's come back to you and tell us what's happened in the last few minutes.
Well, we let go of that clip. It was fine. We're coming down with the third clip here, which is just under the annulus here. We're going to go tight to I think we felt like tight to the second clip was the way to go. So we're down there, kind of all fluoroscopic for me so far. Just kind of getting bearings. We checked our grip arms. We're kind of here.
So Jamie, I'd say you deployed your last clip kind of 2 to 8. Is that fair? And then
yes.
how would you? And what will your angle be on this one?
I think we're going to just parallel or mirror that if we can.
And still try and stay anteroseptal. Is what you're doing, because it looks like there's a canyon between the anterior and posterior leaflets, and you're staying anterior to that, so you're really staying anterior here.
Yes, because it looked to us like the problem was just very close to the other clip. So I think I have them again. What do you think? I think
I think so.
So there's a drop. Here's a lock. We'll try this. Let's just see.
I would also point out here, I think it's great to look at the fluoroscopy and really understand how sort of perfectly oriented you are between clips 2 and 3. They're really paralleling each other well, and I think the fluoroscopy can be of great value in this regard, in addition to looking at your at your orientation on the transgastric or 3D.
Yeah, I'll try and get the mitrals off there for you. It's over here somewhere. I don't know.
Did you close?
Yep. So that's the third one. They get easier as you go along. Once you get your orientation on the first, if you're staying in the same commissure, obviously, once you get your orientation on the first one, you sort of know where you're going, and you can use fluoroscopy a lot more, as Amr mentioned, which makes a number of the steps a little faster. So
this is a gorgeous result so far, guys. I know you're going to look at it more, but this is beautiful.
Thank you. Yeah. So I guess, this is a real sort of bicuspidization technique. We hopefully, we'll see. We'll see how it looks.
So I have a quick question. So after you released that second clip, did you see the septal directed jet go away?
No, not fully away. I think it was still there, which is why we brought in the third clip.
Yeah, we do have a couple images I can share as well. Might be good.
Yeah.
I'm just going back to review. So at that point, that's where we're looking at in short axis. That's why we prompted to go relatively close to the second clip, as you see it here. The origin, if we really push down to the vena contracta, you see it's very close to the previous device. And then here is before we deployed. And then deployed state is 3D, and then in 2D, there were a few bubbles here that came into the way. But again, you see how close we are to the other devices. And here you see it again.
So what about now?
And what about now? So I'm going to go back to mid-esophageal now. Zoom out.
Hey guys, Michael pointed out the radiation protection for the imagers. I see you guys, of course, have the Rampart there. You're not wearing any lead. You look very comfortable and relaxed, no back pain. Is this a standard practice for you guys?
Yes, it is. But Rampart has a great deficit, which is it does not cover the head of the bed. Obviously something that somebody, either Rampart or someone else, needs to work on to protect all members of the team. So we are lucky. That's a nice result, I'd say. We are lucky, but obviously Burkhardt's wearing lead, so that's and our anesthesia colleagues are wearing lead. So it's not perfect yet, but hopefully we get there, because it is nice to not wear lead.
Yes, and I do have a ceiling-mounted shield that we pull in addition to the body protection that I have besides my lead.
And if you can, if the camera is possible to show that big orange shield that you have, Burkhard, that's protecting you there as well, in addition to the apron.
Okay. Can you see
that? I think this is important, right? Like just ergonomically, yes. how this kind of stuff can work out.
Yeah, in theory, with that one, I wouldn't even need a skirt, but have not changed my practice. Still carrying both pieces. And then, yes, I don't know if this shield is seen. It's not optimal because it comes from the feet, but it's an additional shield that's up and takes some of the scatter away as well. So yeah, let me look into the liver actually.
Yeah, it didn't seem like there's a whole lot of TR left. We have to, confirm insertion, of course. But let's see what kind of,
Jamie, this is just an awesome result. It just couldn't look better, in my opinion, at this juncture. And, I give you so much credit. I also think there is something to patient selection here.
Yeah.
And, tell me your thoughts on patient selection and how that contributed to why this was such a great case.
Well, I mean, we picked a person without leads, which is an obvious cheat code for both imaging perspective and just, how you might have to fight with them. There was not a huge coaptation gap here, which certainly makes it easier. We have had some success with relatively large coaptation gaps by doing kind of that zipper technique, starting deep in the commissure and just knowing you're going to do 3 or 4 clips up front. But clearly, for many years we've had kind of one solution, which was Triclip off-label in the tricuspid, and I think we've all kind of learned from that there are certain, just coaptation gaps that are more or less insurmountable. I actually find, we don't get a lot of flail leaflets, but I actually thought flail leaflets would be wonderful for Triclip, but I've actually kind of struggled with them, particularly when they're from a lead extraction. We went through a period where, particularly for leads that were defunct or could be optimized, we tried doing lead removal instead of primary tricuspid therapies, and that didn't go very well for us, I must say. We created a lot of, if it's adherent in the subclavian, it's often adherent to the leaflet too, particularly if they've been in for a while, and created a lot of flails. I mean, this is probably a few years ago, but I struggled with those a little bit. I thought that they were kind of difficult on tricuspids because the flail is just so, particularly when it's a lateral flail, the leaflet's so long it can be very challenging. But so I don't know. I think that it's not a huge annulus, it's not a huge coaptation gap. There's obviously not a lot of hardware in the heart to obscure imaging. Those are all obviously advantages.
A couple more images to quickly share. I don't know if you see the baseline hepatic venous flow reversal where I pointed out the blue systolic flow reversal. The red is the forward flow. And here is the pulse wave Doppler. If we go to now, pulse wave Doppler looks like this. So we have a nice cleanup here, and then the color M mode, and that's why I like doing it. You really see that the blue is gone, and we only have the red forward flow.
Do you have a gradient yet on this? I'm sure it's low.
Let me get that. Good point.
We're going to need to wrap up soon because I want to give the panel time for their final comments. It's an absolutely stunning result and masterfully done in a short period of time. Putting in 3 devices is very impressive.
Thank you. Yeah, we should also just check insertion. We'll let this one go for the grand finale, and then you can look at it.
It's absolutely beautiful, guys. Let me turn to the panel for a sec. In a situation where you've got a patient with MR and TR, you're bringing them for a mitral clip. What's your approach to saying, let's just clip the tricuspid on the way out versus let's wait, see how they respond, and go from there? So let's just go straight down the line, starting with Nadira.
I mean, there's so many of these patients. I think we've done cases on the way out, but more and more so we actually just do the mitral first, and then we get them back, within a month. Diuretics, optimize the medical therapy, and then we assess the TR data as well to see whether,
Okay,
and
we're
at the
gonna let it
time
go.
of the table of the mitral, we also assess intraprocedurally in terms of the tricuspid imaging. What are the thought process? Obviously, is dynamic, is changing, but at least have an idea whether it's a TIR or TTVR. If the gaps are too big, optimize more. So it gives an idea to optimize further within the 30 days and then do further transthoracic imaging.
Well, Nadir, while I have you here, how about the ones you've done the tricuspid first and there was moderate MR? Have you seen any of those go more severe?
The answer is yes.
Yeah, exactly.
The answer is yes. We have, and then they come back. And actually, when they come back, the moderate MR becomes severe, and then actually the TR became severe TR, and the clips were intact. And then the patient were actually obviously overloaded. This is, in a setting of back in their baseline lifestyle, but obviously then we have to optimize medically and think of tackling the mitral.
So, Charlie, are you suggesting that fixing the tricuspid is making the mitral worse?
Yes, I am.
And what's the mechanism?
I've had a handful of cases where that's exactly what happened. Rob, go ahead.
Yeah, with same thing, and this is with TTVR,
Yes.
big R as well. So we've had to do clips on the mitral afterwards when someone had mild to moderate.
And what's the mechanism? Why is this happening?
It's increased.
Forward flow.
Yeah, increased overload on the mitral regurgitation because tricuspid is kind of protecting the mitral valve at some point.
We do. In our replacement cases, we do right heart cath before and after the procedure. And in patients that have borderline MR, we sometimes do see more of a V wave kind of start, peaking up with the wedge tracing. So it certainly is, I think, something that is real.
Give you bubbles.
In terms of combination valve problems, Fabian, what's your approach?
Yeah, I think what is really, really important when you go into combined disease is then to really be aware of what is the etiology of the disease. That's really something you need to look at before you go into these cases to be sure that if you have, for example, two primary lesions, then you will know that this is very unlikely. Even if you are very successful to treat the mitral valve, it will be quite unlikely to correct by itself. So that's typically the case where I treat both sides at the same time.
Same time.
And rather than waiting for the improvement that will probably not come if you have a flail or a Barlow valve on both sides, for example. But the etiology is quite important there. Beautiful result, by the way.
Yes, thank you. So this is 3 clips deployed. I think we're kind of done here. A little bit of a jet between, what's that, between 1 and 2 or 2 and 3? I can't really tell, but
between, I think 1 and 2 actually.
Yeah. Not a whole lot of space there, but
far.
Yeah.
And this is, as Michael said, this is not even perfection and pragmatism. This is perfection and more perfection, Jamie. So I think this is beautiful.
Thank you.
So, Jamie and Christine, tell me your thoughts on. We're going to see TRISCEND 2 data tomorrow. What are you guys predicting, and how's that going to, when we have a case like this that is amenable to both technologies, how do you choose one or the other?
What do you think, Christine?
Yeah, I think we know that the replacement devices lead to much less residual TR, but it certainly comes at a cost. There's a much higher rate of pacemaker and just overall increased adverse events. And so, I think Jamie and I were sort of discussing this earlier, that when you have a patient that you think you can get a acceptable result and with a better safety profile, that tricuspid clipping may be sufficient to give them the improvement in quality of life to kind of get them where they want to be. But certainly if people have really large coaptation gaps that you think are going to be too hostile for a good result with clip, then, starting out with a replacement option may be justified.
Yeah, we're basically a clip-first center at the present moment. Part of that is just that the commercialization of Evoke has been, I don't know, for us it's been very hard to screen anyone in. And we're not able to evaluate that opportunity ourselves, which I think is really fundamentally a misstep. So that part's been hard. If they can show if TRISCEND shows mortality data that the Trilumate doesn't yet have, then I suppose you're going to have quote unquote shared decision making around relative risk versus benefit for replacement, but it also includes anticoagulation. So for people like this who have persistent AFib and they're anticoagulated anyway, perhaps that's not a big deal, but in someone who is, where that's a more important aspect of the decision, you're going to have to factor that in too, probably. So I don't know. I think it's going to be a place that we probably, it's a path we're going to stumble off a couple times figuring out what's exactly right, I imagine.
All right, well, thank you guys, Christine, Jamie, Burkhard, rest of the team at UW. Thanks for showing us how it should be done. We've got 3 minutes and 6 panelists, maybe 15, 20-second closing thoughts starting down the line.
Fantastic case, Jamie, Burkhard, and Christine. Beautifully case. The only thing that I wanted to say is the left-right groin. I noticed that he went on the left groin. Was it a standard practice among the different practices? We didn't get a chance to speak that, but this really showcase the role of interventional imager like myself that is so key to the success of the outcome of these procedures.
Yeah, you're 100% right.
Totally echo that. It's not a simple case, but still the result is great. Obviously, it shows the yield of the combination of transgastric, transesophageal, but also ice in this situation, which they didn't use a lot, but still we can see the yield of it. And the importance of perfection again and achievable even next year.
I think that it just goes to show that, with a great team, great imaging, and, picking the right patients, that you can get a phenomenal result. And, 3 clips in, however much time it was in one session is really impressive.
I mean, I think the team makes it look very easy, but it was not such an easy case. And what's very interesting for me is heartbeat. Obviously, the heartbeat was 120 all the time, so it was uncontrolled atrial fibrillation. That's a situation where you can really, really struggle when you are a beginner with this kind of therapy. So nobody noticed actually, but that was not so easy.
Great point. Brian.
Yeah, I think this was a great case in terms of anatomy and both good imaging as well as small coaptation gaps. I do believe that large coaptation gaps can be very challenging. And I've moved more towards transgastric grasping, as Jamie did in this case, and I'm impressed from this case, and I'm going to do it more. And I trust the transgastric view. That's a super important part of this procedure.
Yeah, I think the result of this case is fantastic. Our default has always been to go towards a cloverleaf approach towards fixing these things. This is a beautiful demonstration of how bicuspidization can really work. Obviously, it was a really well-picked case as well, so I think that kind of served its purpose for this demonstration. I am very interested about the elevated heart rate and what happens when you have tachycardia-mediated cardiomyopathy coming up next, and then you're going for pacer and ablation, and how do you manage that in this circumstance? I think that'll be kind of an interesting kind of down the road issue to deal with.
Charlie?
Yeah, no, I think this is a result that is not going to be achieved in many people's hands. This was the highly skilled group that had a great result. This becomes the seduction of replacement because it's a little more friendly with imaging technique, time, and all of those. But I caution that with that, the same skills need to be applied. Otherwise, you're going to be having valves canted or flying around in the right ventricle. So whatever one you pick, and I think this one could have gone either way, we probably would have done a replacement on it. But I caution about the excitement there's going to be with valve replacement only because of the simplicity compared to what this took, although they made this look awful simple.
All wonderful lessons, fantastic comments. I would also highlight just the communication between the IC team and the imaging team. Clearly, they both understood what the other was doing, and there was a constant communication there that yielded the results they had. But thanks to the panel, thanks to my co-moderator, Charlie Davidson, and thanks to all of you for staying till the end.